So we have a 2-year cycle. Cami Gunton runs our pediatric, the residency kind of stuff for you guys, and cover the most important topics we think for you to learn. And when it comes to glaucoma, glaucoma is such a broad field. So to have 1 hour, instead of trying to teach you everything you need to know about glaucoma or concentrating on one aspect of pediatric glaucoma, what I'm going to do is just give you some of the top tips in managing pediatric glaucoma, so kind of some general principles that are overarching that will apply to any part of glaucoma that you treat. Now, having said that, it is important to understand that glaucoma is an uncommon disorder in childhood. The incidence of infantile glaucoma, for example, is 1 in 4,000 to 10,000. But it's a manifestation of many different forms of pediatric ophthalmic disease, and we'll try and broaden that up for you. So, tip number 1. When you see a kid in the clinic or in the emergency room and you're thinking, does this kid have glaucoma, we have to look at things that can mimic glaucoma. And virtually every symptom or sign that we have of glaucoma can look like something else. So, for example, the classic sign of infantile glaucoma is the kid who's got photophobia and tearing, which in glaucoma, good morning, Chief, which in glaucoma is due to the corneal edema that they get from the high pressure. The high pressure in the eye causes endothelial dysfunction, therefore you get corneal edema and all these symptoms. But I don't have to teach you that there's a long list of things that can cause photophobia and tearing in children. All of these things on the list can mimic. A kid with achromatopsia, for example, has severe photophobia when they come in. They barely open their eyes sometimes. There's also functional photophobia. We have kids who say that bright lights bother them, and there's nothing wrong with them at all, a common ER problem. One thing that's really important to remember is that nasolacrimal duct obstruction, which is a cause of tearing, is almost always in infants associated with discharge. In fact, they have discharge more than tearing. And I have 2 kids in my practice who were followed for nasolacrimal duct obstruction when they had glaucoma. And one of those kids didn't get to me until they had nystagmus and 0.99 cups. So, on the one hand, we have to make sure that we do a thorough evaluation of every child to rule out glaucoma, but we're looking for those mockingbirds. Really, it's just this. And when it comes to tear duct obstruction, we really expect to see discharge. It's usually worse on waking. You have the mattering of the eyelashes that Dr. Schnall was talking about the other day in Chiefs rounds, but they really don't have any photophobia. They just have tearing, and that's an important distinction. Large cornea. Large cornea can be from many different things. Certainly it can be from the stretching of glaucoma. There's a condition called X-linked recessive megalocornea. There's an autosomal recessive form called Neuhauser syndrome with developmental delay. Sometimes you just have people with big eyes. That runs in families. It's usually autosomal dominant. Sturge-Weber and any other syndrome that's associated with overgrowth, neurofibromatosis and others, can have a big eye without glaucoma. And there is a very rare entity called spontaneously resolved glaucoma, in which we see kids with a big eye. They have Hobbs-stria in the back of their cornea that breaks in the endothelium. And for all intents and purposes, they look like glaucoma, but they have no edema. Their cups are normal. Their pressures are normal. They had glaucoma that resolved as the angle matured. The goniodygenesis resolved as they got older. So we're always thinking about other things. So here's a patient with a large eye, about a 14-millimeter eye, with high myopia, with radial iris transillumination. And one thing that's not as shown well in this photograph is I keep forgetting to change this, but you can see the angle of the eye without a gonioscope. And that's called X-linked megalocornea. I've seen 2 children who've had glaucoma surgery for this disease without having glaucoma. Really important to take a look for these signs and to look for other things. Anybody want to take a venture? So cloudy cornea is one of the manifestations of infantile glaucoma. We're always concerned about cloudy cornea. So here's a kid. So Josh, tell me, what do you see here? Forget the UBM for a second. What do you see here?
A large cornea?
It's actually not that large, which is important. It's actually normal size for a baby. So let's say this is a 10.5 millimeter cornea, which is a big photograph.
It's cloudy. It appears to be.
And how's it cloudy?
Almost looks like underneath there's sort of a milky.
Right. See how the light reflex is great? No really epithelial edema here. Okay? This is deep stromal density. Sometimes there could be epithelial edema with this condition. It's completely opaque, which is really unusual. The only time we see an opaque cornea in glaucoma is in the congenital form of glaucoma, where they come in with big white eyes. So this eye's not white. And what do you notice about the UBM? Do you notice anything unusual here? Really thick, right? Hugely thick. And this is a disorder called CHED, congenital hereditary endothelial dystrophy, which there's some thought could be associated with glaucoma in infancy. But if you're going to have an eye that's this cloudy, or it's going to have corneal edema, and you're going to blame glaucoma, it's got to be a big eye. Okay? Here's a regular-sized eye with a white cornea. It just doesn't look like. And those are the kind of decisions we need to make in determining what is the nature of this corneal opacity. So tip number 1, watch out for mockingbirds. Even Hobstria, the breaks in the back of the cornea, have mockingbirds. Forceps injury, okay, causes breaks in Descemet's membrane. Now, when we look at the breaks in Descemet's membrane in glaucoma, they're always scalloped. And remember, when Descemet's membrane breaks, the two ends come apart, right? And in glaucoma, they're always scalloped, and they go in every direction. They can spin around. They can go anywhere you want. Whereas forceps injuries, the breaks are always straight, and it's almost always oblique and single. Think about it. The forceps goes on the eye like that. They're always unilateral. It's virtually impossible to get bilateral forceps injury. The unlucky obstetrician would have to put the forceps in, one on the eye, one on the other side of the head, would have to rotate the baby 180 degrees, put the forceps back on to get the other eye. It's impossible, right? So they're always unilateral. But they can have corneal edema. The eye's a normal size. So we put all the factors together. And my favorite is when the resident comes to tell me it's a forceps injury, and we ask the mom, did they use forceps? And she says no. And believe me, after having watched my son delivered by mid-forceps, I can't imagine there's a woman in the world who was conscious during her delivery who will not ever forget the use of forceps. So, you better have a history that they use forceps before you make a diagnosis of a forceps injury. Other things that can cause things that look like breaks or are breaks in Descemet or syphilis. Don't forget covert trauma. Some kid got punched in the eye, that could cause it. Descemet's folds can be something that fools you. And in rubella, congenital rubella, a disorder that causes infantile glaucoma, you can get an endotheliitis from the inflammation that looks like Hobstria. So all these things have a differential, and we can go on and on about that for the hour, but we're not. There's many things. Yes?
Is that the same mechanism for syphilis? Is it an endotheliitis? Or
Yeah, same kind of. Tip number 2, don't forget glaucoma, right? As much as we want to not overdiagnose it, same thing as we don't want to forget it. Here we get back to our kid with blocked tear ducts, right? And we shouldn't be thinking about glaucoma here, right? There's a kid, he's got the mattering of the eyelashes, he's got his discharge, he's got tearing. I mean, that's easy. Don't put in your diagnosis. But if we look at the list of things which we know are associated with glaucoma, these kids need routine, regular follow-up. For example, Axenfeld Rieger, aniridia, twice a year we'll put the kid under anesthesia if we have to make sure they don't have glaucoma. Their risk for glaucoma is 50%. Huge. Aphakia. At least once a year, we'll do an exam under anesthesia if we have to. The risk in glaucoma, the most common cause of glaucoma in childhood is cataract surgery. So whether you're aphakic or pseudo-phakic, every visit they come, we are thinking of glaucoma. And you'll see that I'll harp on you in clinic that when they come, you got to over-refract their contact lens, looking for a myopic shift from an increasing eye. We're looking for corneal edema. We're looking at the optic nerve. We've got to be thinking every visit, could this kid be developing glaucoma? Kids with iritis and trauma are at high risk. I often see kids in the emergency room where I see angle recession glaucoma. It turns out kids don't get angle recession glaucoma. We did a 20-year follow-up study that showed no angle recession glaucoma. But yet we know they're at risk. So all of these entities, that should say JIA, we now call it juvenile idiopathic arthritis, are kids who are high risk for glaucoma and need to be followed. If you look, 50% risk. Iris hypoplasia, 50% risk. Other anterior segment degenesis, some even higher than 50% risk. You must constantly be thinking of that. And also remember that everything is relative. So we said we're looking for an eye that's getting bigger from infantile glaucoma. What if the kid is born with a microphthalmic eye, as we often see in kids with cataract? So now, let's say for age, the cornea in this kid is supposed to be 11, but they started out at 9 and had cataract surgery. And in the space of 3 months, they go for 6 months, they go from 9 to 10. Whereas the other eye, which is normal, has only gone from 11 to 11.25. Well, the microphthalmic eye is still microphthalmic compared to normal, but it's increasing in size much too rapidly and therefore has glaucoma, the most common cause of glaucoma, aphakic glaucoma, even though it's still small, right? We look for the myopic shift. Well, a baby's eye is plus 32, an aphakic eye, after cataract surgery. If that plus 32, 3 months later or 4 months later, is plus 22, is that a problem? Well, we know that they do decline fairly steeply, but maybe not that steeply. So any rapid shifts, even though it may still be normal, the speed of the shift may be the indicator that, relatively speaking, the kid's growing too fast and has glaucoma. We talk about eye size changes in general. When you read the basic science course and other things, they often talk about up to 2 to 3 years, but they can actually occur to 5 to 6 years as well. Tip number 3, do pachymetry. And this is really important. But at the same time, don't rely on it too much. What do I mean by that? Well, this comes from a study that we did some time ago and published. And what we know is that the corneal thickness in children normally is bigger than adults up to about the age of 5. So a preemie can be in the 600s, full-term newborns in the high 500s. You don't get down to that kind of 545 average until you get to about 5 years of age. Now, you are all familiar with this kind of graph, right? Where as you get thinner, you take off a point, you take off 2 points, take off 3 points, and as the cornea gets thicker, you add points in this direction when it's thinner, and as it gets thicker, you're taking off points. And I'm sure you're all familiar with the concept that the thicker the cornea, the more the applanating instrument feels a harder pressure than is really there, right? And the thinner the cornea, the more the applanating instrument feels a pressure that's lower than it actually is. And these can lead to changes in your diagnostic criteria. But in pediatrics, we've got a problem because we see corneas that are unlike anything you see in glaucoma clinic. It is not uncommon for a kid with infantile glaucoma to have corneas after their edema is resolved in the low 400s or even 390s. We think that's because the fluid gets squeezed out of the cornea. And then thick corneas, over 800, over 900, are normal in aphakes and pseudophakes and aniridia and microphthalmic eyes especially. It's part of the malformation complex. So we're way off of the curves that you guys use in adulthood. And if we were to use that table I just showed you, which creates this kind of graph, this linear graph that takes you from about 650 down to about 450 and gives you this linear +1, -1 adjustment. I live here and I live here. And the question is, well, if I live down here and I've got a cornea that's 900, am I going to take off 25 points? Right? That's what the linear graph would tell me. Because if I did that, I'm going to start having kids with negative adjusted IOPs, -10. And obviously that can't physiologically be correct. So this is from a large population. We studied the 206. And what we know now is there is an asymptotic relationship. That at some point, the effect of additional added pressure, added thickness, doesn't affect the pressure as much. There's also other factors in pediatrics that we don't deal with as much in adults. Number one, what does a cornea look like? We see a lot of funky corneas. Peters anomaly with a scarred cornea, 50% risk or higher for glaucoma. So what's the corneal hysteresis? What's the rigidity and compliance of this cornea? We don't have a way of measuring that in children. There's no instrument that we can conveniently use in young children. So it's really kind of a guess. This doesn't look right to me. Pressure, well, what do we do with that information? Where are you measuring on the cornea? First of all, on a moving child, it's like a moving target trying to do pachymetry. You may be measuring more peripheral cornea where it's thicker than central cornea. And sometimes we can't. The pachymeter won't read over some of the malformed corneas that we have. So we'll take a measurement away from the scar, let's say, away from the Peters anomaly, and deal with that. Is there epithelial edema? We know that when there's true epithelial edema, the cornea is thicker, right? But there's a disproportionate decrease in what the machine reads. So a baby who's got corneal epithelial edema from their infantile glaucoma can have a low pressure because it's measuring in a marshmallow bed, right? And lastly, what's the phase of the disease? Where is it in the disease? Do I expect a high pressure or not? So we're always looking for the other signs of glaucoma. Is there corneal edema? Is there corneal diameter changing? Is the length of the eye changing? What's the optic nerve look like, et cetera, et cetera, et cetera? Pachymetry is just one piece of the puzzle. We don't have a formula like you have in adults because we live in the Netherlands of pachymetry numbers. But we use that information importantly, and I'll show you that in just a second. So really, in conclusion about pachymetry, I think the 4 basic points to remember is really important in context. Let me give you an example. The other day I saw a kid did an EUA yesterday, and the kid had persistent fetal vasculature, aphakic in one eye, normal in the other eye. The pressure is 24 in the eye with aphakia, no other signs of glaucoma, and it's 14 in the normal eye. But the pachymetry is 800 in the persistent fetal vasculature eye, and it's 545 in the normal eye. Well, I'm okay with that, right? I'm okay with that difference. That explains my difference. I don't need a formula to tell me does 24 get me to 14, but I've got an explanation of why those two eyes are different. There are no nomograms to adjust IOP in children. CCT is one factor in determining the glaucoma status, and pachymetry should be a part. So if you're in my clinic and you're seeing a kid for rule-out glaucoma, and you don't tell me just the pressure, I want to know what the pachymetry is. Or you're going to show me a kid with a high pressure, I want to know what the pachymetry is. If you can get it, it's an important piece of information. Tip number 4 follows from number 3, and number 2 and number 1. And that is glaucoma in childhood is a jigsaw puzzle. And you got to put it all together. And the least important piece of information is the IOP. The IOP is the least important information. It's all the other things in this developing eye that make a difference. So let me give you a case. A 3-year-old kid comes in for an aphakic glaucoma for their annual routine check. Their pressure is 29. The cup to disc is, it's a real case, 0.1, stable refraction, stable axial length, stable corneal diameter, and a CCT of 724. Does the kid have glaucoma? Chief, what do you think?
They may have glaucoma, but that pressure of 29 doesn't necessarily mean they're getting worse. That's sort of a counter.
Say it again, I'm sorry.
They may have glaucoma, but that pressure of 29 does not necessarily mean that they're poorly controlled or progressing. You could explain that. All the other signs are stable, and the CCT could, help to explain why.
So I think that's the perfect answer. I can't prove to you that they don't have glaucoma, but there's no other signs of glaucoma at all. The pressure is the least important thing here. Am I going to watch this kid a little closer? Yeah, I think I would like to see this kid instead of waiting a year. But I'm not going to treat this kid. I have a kid in my practice who's this exact child who had been treated with 4 drugs for glaucoma. Cup is 0.1. Everything else is perfect. So I started taking away drugs. I took away drug after drug after drug. And finally, when I took away the last drug, the pressure went up into the high 30s. So the kid did have glaucoma. but was over-treated based solely on pressure. And the pressure never went down from 29 lower. That's the kid's baseline pressure with all that treatment. Went down from the 30s to 12, couldn't get below that. So we can't tell you for sure what the adjusted pressure is, but with a CCT of 724 and no other signs of glaucoma, maybe a cornea's a little scarred or whatever, there's no signs of glaucoma here. We just follow. Look at this kid. Ophthalmos, big eye, corneal epithelial edema, Hobstria, cupping of 0.7, classic gonioscopy for infantile glaucoma, CCT stick because it's 602 because of the edema, and the pressure is 12. Does this kid have glaucoma? Absolutely. Are you going to do surgery on this kid? I see heads shaking. For sure. That's the marshmallow bed that you're, I didn't see Sonia back there. Good, I can ask her questions. So absolutely the kid's got glaucoma. There's a perfect example where the IOP is the least important piece of information. Right? The least important piece of information. Tip number 5. You know what? Some people don't like pediatrics because they think it's veterinary medicine. Because our kids sometimes don't comply with what we like. We love that, but we also understand that we're not going to, there's only so much we can do holding a kid down. And you can't get a pressure in a screaming child. Please don't call me. You can call me in the middle of the night for anything, anytime. But please don't call me to tell me that you measured a pressure of 50 with a speculum in a screaming child. That shouldn't even go on the chart, right? Pressure in a screaming child. You can write a pressure, he was squeezing, and we write that sometimes. Pressure is 22, child squeezing, right? Child squirmy. But when you need accurate values, sometimes we have to put the kid to sleep or under sedation, and conscious sedation is coming, by the way, to Jefferson Pediatrics. General anesthesia basically has little or no risk in childhood. The risk of a kid dying or having brain damage has been calculated as less than the risk of those things happening in the car coming to the hospital. We avoid ketamine, which raises intraocular pressure. We avoid halothane, which lowers intraocular pressure. And usually we're using the same protocol every time, so we don't worry about the anesthetic effects on pressure too much. But as far as we know, there's no long-term effect in all the studies. Dr. Dix is actually writing an editorial right now on this. There's no convincing studies that there's a long-term effect of general anesthesia on kids. But at the same time, don't forget to examine the kids awake. Dr. Shah, I'm sorry. What is the most common cause of visual loss in pediatric glaucoma?
Amblyopia.
Right? You've got to be checking these kids' vision. Can't do that asleep. You've got to be checking their strabismus. You've got to be checking for an afferent pupillary defect. And Dr. Shah is absolutely right. The most common cause of visual loss in pediatric glaucoma is amblyopia. The most common cause of visual loss in pediatric cataract is amblyopia. Every pediatric condition, that's our arch nemesis. And I have seen patients who've had nothing but examinations under anesthesia for 5, 6, 7 years of their lives, and no one ever took their vision. Right? It's kind of like the patients on pilocarpine in adult glaucoma clinic where you keep writing on pilo, dilate next visit, and it goes for 4 years. Same thing. We got to stop and take their vision, look for strabismus, look for an afferent pupillary defect, and do that awake. Tip number 7, treat the specific glaucoma type. One of the wonderful things that makes pediatric glaucoma so fun is there's all kinds of challenges based on the development of the child. So this child, of course, has Sturge-Weber syndrome with a port wine mark on her face, and she has a choroidal hemangioma in her eye, and she has glaucoma. You can see that her right eye is bigger than her left eye. And we know that in Sturge-Weber syndrome, there's 3 different kinds of glaucoma. There's an infantile form of glaucoma, rarely congenital, that presents in the first few months of life, and these are out of scale, which is a high peak. And then there's another peak that occurs due to increased episcleral venous pressure, somewhere between the ages of 4 and 14. And then they have a smaller peak of POAG as adults. Well, how are you going to treat a goniodysgenesis? Well, in children, generally what we're trying to do is open up the pathway from the anterior chamber to Schlemm's canal, and we do that through goniotomy or trabeculotomy, and various forms of that. When you get to the second peak, that won't help anymore. because the fluid can't get out of the eye. You have to bypass the standard pathway, and therefore we talk about using tubes primarily and sometimes trabeculectomy. You don't have to have infantile glaucoma to get this one or vice versa. You can have any combination or just one or two of these three. And in each child, we're asking that question: why does this child have glaucoma today? What's the appropriate treatment to address that glaucoma? Here's a child with aniridia. There's multiple causes of glaucoma in childhood aniridia. There's goniodysgenesis, which is just like any infantile glaucoma. There's the iris stub that's there turning up into the angle, which is a progressive phenomenon that occurs over time, which we treat by a form of goniotomy called goniosurgery, where we actually push that iris down and open up the angle at the same time. So same procedure, but different way of doing it. And then there's Schlemm's canal agenesis. And that there's no way to figure out unless you try and do a trabeculotomy and don't find Schlemm's canal, or you do a goniotomy and there's no improvement at all. That's usually a sign that they have no Schlemm's canal, in which case all the goniosurgery in the world is not going to work. You don't have a Schlemm's canal. You have to bypass the system with a tube or with a trabeculectomy, usually a tube in childhood. And that's another example. We often don't do trabeculectomy in childhood because we recognize that mitomycin is absolutely necessary in a child, except for the rare circumstance of hyphema, where if we do surgery, we do a planned failure trabeculectomy and let the trab close on its own over time, because these kids, we know, 99% of their glaucoma will go away. So we're always picking our procedures and our interventions based on the type of glaucoma and the age of the child. One thing that's fairly new over the last 5 years or so is the use of goniosurgery, goniotomy, in uveitic glaucoma. That's our first-line surgery now. I don't know why it doesn't work in adults, but in children, we do goniotomy that has about a 70 to 80% success rate. So knowing the age, knowing the disease helps us plan a course of treatment. Tip number 8, push medicines when you can. It's, if you had to have like a little cheat card in your wallet for pediatric glaucoma, it would say push medicines when you can. And there's a lot of reasons for that. Medication is almost always better than surgery if you can control the IOP. The only time surgery is absolutely indicated, as opposed to medicines, is in infantile glaucoma, where there's a goniodysgenesis. And there it's just a matter of time. We know that some of those kids would resolve if we didn't treat them. But surgery, you got to open up. There's a block, there's a wall between the anterior chamber and Schlemm's canal, and that surgery is our treatment of choice. But remember that surgery does not guarantee no medicines, and about 50 to 60% of children with any glaucoma surgery will still need medicines. But I can tell you, if you lined up in this room 100 patients, parents from my practice, and you asked them, would you rather have surgery or have medicines? Would you rather have surgery than 4 different eye drops and Diamox 4 times a day? They would all pick medicines, because you cannot underestimate the impact of surgery on a family and on a child. It's huge. When you sign up a patient for a trabeculectomy in glaucoma clinic who's 65 years old and can make their own decisions and alter their lifestyle, that is hugely different than what it's going to take to do to a family to do surgery. And for all of the glaucoma entities, medicines are better, except for goniodysgenesis, where we have to do surgery. And when surgery is done, if it looks like it's not working, we always push medicines before we go to a next operation, or almost always. Tip number 9 is a strange one, but it's important, and I put this in because of you guys seeing kids in the emergency room. Atropine can be a fantastic glaucoma medication in childhood. Doesn't work in adults. And the reason is that when we see closed-angle glaucoma, acute glaucoma in childhood, it's very rare. It's either in persistent fetal vasculature, stage 5 retinopathy of prematurity, where there's a total retinal detachment and anterior loop traction, which pushes the anterior chamber closed. We see it in microspherophakia, I should add to the list, vitreous hemorrhage, total RD, aphakic glaucoma, rarely can this happen. The point is that because a kid's ciliary body is so juicy, an infant has 14, 16, 20 diopters of accommodation, Atropine is very powerful in relaxing that ciliary body, and you get that proportionate amount of turning back of the iris ciliary diaphragm, iris lens diaphragm. So you can do amazing things. So kid comes in to the ER, classic presentation of the kid with ROP. He's blind. He's got stage 5 ROP. He's got a central corneal scar because his lens is touching his cornea, and he's got acute glaucoma. The kid's screaming. You can't measure the pressure, but there's corneal edema. The eye's a little red. That's like classic picture. You can give that kid a drop of atropine or even cyclopentolate in the ER as a test, and look at them 30 minutes later, the kid will be happy as a clam. The anterior chamber will be deeper. The corneal edema will go away. It's an amazing drug. Sometimes in microspherophakia, without getting into great details, I have a kid I just saw the other day with microspherophakia who I have on atropine. He's been on atropine for a few years now. He's got glasses to read for the atropinized refractive error with bifocals, but it's prevented him from having surgery, and he's doing great. Tried to stop the atropine, pressure went up to the 30s. Because of microspherophakia, things are coming forward. Tip number 10, although we try and avoid surgery and do all these manipulations, what we've learned over time is that if you do cetons earlier in kids, tubes earlier, the kids do better. It used to be that we used tubes as our last resort. Now we know that if we use them as a first resort, the outcomes are better. And this started with actually work we did that was published some time ago in 2003, and I like to think really changed in many ways the landscape of tube surgery in childhood. And what we found was that at 2 years, if you do a ceton surgery as your first treatment, meaning the first treatment, say, for aphakic glaucoma, or really the first treatment in any case where goniosurgery is not indicated, or where goniosurgery was done and you did a tube before trabeculectomy, you get a 93% success rate. In fact, I think we had 100 tubes in that study. The only failure we've had was a self-abuse. A kid who came in the next day, a developmentally delayed kid, doing this to his tube. That was unfortunate. So they work really well if you do them earlier. And therefore, we've kind of shifted the whole game plan for glaucoma to make tubes in children really our first choice. And part of the reason is also, since you have to use mitomycin in childhood, you don't want a mitomycin bleb for the rest of the child's life. If the cumulative risk of infection year after year is rising, my patients are going to live 100 years. I don't mind taking a cumulative risk in an 85-year-old who's going to live maybe 2 or 3 more years. But my patients have 100 years left in their life, and therefore tubes tend to work better. If you're going to use mitomycin, we have to avoid what we call the ring of steel. And in childhood, they scar so much more aggressively than adults that when we do glaucoma surgery, we don't want to get this bleb, right, for the rest of the lifetime. So we do some surgery that was originally coined by Penn Cole in the United Kingdom, where we make our incisions at the limbus and we put our mitomycin posteriorly. We tend to leave drainage a little bit loose in kids. We can't do releasable sutures and all those other fancy things you do in adults. Our children wouldn't sit for that, obviously. But what we're trying to do is instead of doing when you do a limbal incision, when you do a fornix incision, we get this ring of steel here that actually encloses the bleb in childhood because of the dense fibrosis that occurs behind it, and it forces the mitomycin over the trab site, and we get these kind of bad blebs. So instead, by doing this technique with a limbal incision, as you see here, and spreading the mitomycin at lower dose, by the way, because of the thin sclera in these children, we tend to avoid those kind of blebs. Tip number 12, another thing that's completely revolutionized our approach to pediatric glaucoma is using an endoscope. And we do a lot of things endoscopically. The endoscope takes some training. It's a little weird to do because when you're doing it, you're going against the number one, never take your eyes away from the microscope that we're all taught learning to do eye surgery. Well, here you're going to take your eyes and look away somewhere else to do your surgery. And it's really kind of weird when you start doing endoscopic surgery. It's like just strange because you're not seeing what your hands are doing, and things on the screen, of course, move opposite. So if you want to go to the right, you're moving your hand to the left. right? And without visual guidance, looking at on the screen, it's weird. It takes time to make that happen. And we have a course. I'm doing the course tonight with my fellow, but very easy to do once you learn how to do it. In the old days, we had contact as our way to do this. And the problem with contact treatments in childhood is the anatomy of the eye inside is totally messed up. It's so weird inside there. We see such things, and we go in with the endoscope in child for cataract-related things and other reasons. We just see the weirdest stuff going on inside their eyes. And I'm reminded of a case that I had when we first got our endoscope many years ago when I was in Canada. I had a kid who had bad infantile glaucoma, pressures in the 40s. Everything else had failed. She had conjunctival scarring, couldn't do anything. I did 4 different sittings of contact YAG laser. No effect. I did 4 sittings of cryo. Still pressure in the 40s. Then we got our YAG, then we got our endoscope, and I went in and I found that I had not killed a single ciliary process. 8 separate contact treatments. Why? Because our ciliary processes were just like a weird place. And that's part of the malformation complex of pediatric glaucoma. And now we can look in an aphakic eye. We can go through an anterior approach, sometimes through the pars plana. In a phakic eye, we can treat on top of the lens and go and hit the heads of the ciliary process. In a pseudophakic eye, we can go either anterior or posterior. And we can really do a titrated treatment of the ciliary processes. And the good news is it's a lot easier surgery than a tube, let's say. The bad news is kids do one other strange thing. Their ciliary processes grow back. And we can see that. It's kind of cool. When you see them growing back, it's a little bit unnerving. But we know that we do have to go back and retreat from time to time in these kids. Here you see phakic. I didn't bring any videos today, but here you see phakic endoscopic diode treatment where we can treat the heads of the process. And we'll talk in a second a little bit more about, but this is only going to give you a smaller shift in your pressure and therefore is only used in certain circumstances. What are the indications? They're still emerging. We don't know. Some people use it as a primary treatment now in aphakic glaucoma. But in aphakic glaucoma, there's multiple causes of glaucoma. So, for example, in some aphakics, we believe that they have a goniodygenesis. And had they not had their cataract removed, they would have gone on to get glaucoma anyway, a test that we can never do. But when you do gonioscopy, it looks just like an infantile glaucoma. So for those patients, we'll do goniotomy, and it'll work. But for other patients, if the angle is normal, goniotomy is not going to work. In those cases, then endoscopy becomes a great option. For touch-ups and small changes, it's such a low-risk surgery, phakic or pseudophakic or aphakic. For want to get the pressure down from high 20s to high teens, that's not a bad treatment. It's not putting the kid through all of the rigor of a tube. When there's no conjunctival access to do a good speculectomy or tubes for whatever reason, whatever the malformation or surgery the kid has had, and we sometimes do it with other procedures. So if one of our pediatric cornea surgeons has got the open sky, they've got the cornea off in a kid who's on multiple meds with glaucoma, sometimes I'll go in, do endoscopic diode before they put the new cornea back on as an adjunct procedure or with a cataract surgery. We don't know yet what's right. That research is still trying to figure all this out, but these are some of the situations in which we consider endoscopic surgery. We know there are certain situations where we should not do endoscopic surgery. Uveitic glaucoma, we try and avoid at all costs, just like we try and avoid IOLs in children with uveitis. The child's eye is inflammatory to begin with compared to an adult. Putting an IOL in a child is much more inflammatory than in an adult. That's without uveitis. Add uveitis on top of it, and we can really get some dramatic responses with pressure spikes and bad things happening. In persistent fetal vasculature, we can't do endoscopy, and it's relatively contraindicated because part of the malformation is not just one vessel going to the back of the lens. It's the whole anterior vitreous face is abnormal, and the ciliary processes are pulled up against the back of the iris, creating a sling behind the lens, so you can't get them, you can't treat them. They're way up behind the iris where they're inaccessible. We talked about phakic treatment has its limitations. We try and avoid any kind of pars plana incision in kids who have ROP. Kids with ROP get what's called anterior loop traction, and the pars plana no longer is the pars plana. It's got retina on it, and that's always a little bit disconcerting. And in kids who have an intact vitreous, going in with the laser can cause a mess, right? That's why in aphakic and pseudophakic kids, they've all had an anterior vitrectomy as part of their surgery, or most of them. We've got a little bit of an open window in there. We don't have to worry about vitreous wicking. There's lots of other uses, just as an aside, besides glaucoma. We use it in all my persistent fetal vascular surgery cases. We use endoscopy for a number of reasons. Sometimes in cataract surgery, IOL, because kids get so much scarring in their eyes. Sometimes we'll go in to help us figure out how to get the IOL out of an eye. Helps us find the nidus that's creating residual cortex. Sometimes we just use it to see what the heck is going on inside this eye when we can't figure out the anatomy. I had a kid a few months ago. I did endoscopy on as part of a PFV case. It's a shame we didn't record it. The kid's retina, we would have never been able to see this, grew. There was no aura. It grew up over the pars plana, behind the iris, behind the lens. So when I did my posterior capsulotomy, unwittingly, I was going through retina. He had an eyeball completely lined with retina for 360 degrees. Wasn't pleased to find that, but it certainly helped us in the management of the child thereafter. So we see all kinds of bizarre things in the childhood developmental abnormalities. Tip number 13, as we're winding down, is accept less information. You want to do this, you just have to accept the fact that kids don't do what we want them to all the time. And therefore, if we have to accept less information, we do. There are alternatives to checking IOP. Is there corneal edema? What's the anterior chamber depth is important. Is it shallow? Is it deep? When an adult comes in for their first post-op visit after a trab or a tube, you take their pressure and you kind of figure it out. I don't have that luxury. I've got to look at the eye and say, well, anterior chamber shallow. Corneal edema, is the corneal edema from surgery, or does it mean that pressure is high and the anterior chamber is shallow? What's that formula? Or deep edema? I have to make it up without the availability of an IOP measurement. The fundus exam can help. After Sturge-Weber, is there a choroidal effusion, which usually means there's a low pressure? What's the nature of the bleb? If I can see the bleb, half the time I can't even see the bleb or the surgical site in a child. Although we'll put a speculum in if we have to. And a lot of this comes down to just experience and being through it, and we'll get back to that in a second. Finger tension is something that we do use in kids from time to time when we have to. It ain't exact. It's an art. It ain't a science. We try to avoid it in the immediately post-operative period because kids' sclera is so soft you can very easily open a wound, or a leak, I should say, around the tube, for example. But sometimes we have to do what we have to do. Which leads me to tip number 14. Kids are not miniature adults. If kids were miniature adults, I wouldn't have a job. There wouldn't be a pediatric ophthalmology department. There wouldn't be children's hospitals. There wouldn't be pediatricians, right? There's a reason. They are different. Their anatomy is different. Their physiology is different. Their behavior is different. Their psychosocial circumstances are different. And therefore, we can't use our adult rules to take care of kids. Some examples. We never use brimonidine in infants. Brimonidine, 1 drop of brimonidine, I've had this happen to me, and we've published this, 1 drop of brimonidine could put a kid in a neonatal intensive care unit. Why? They get bradycardia, they get apnea, they get hypothermia, because this drug crosses the blood-brain barrier. All of the serious intensive care unit cases were in children under 3 months. In general, we try to avoid it in the first year of life to be safe. No one's ever died, fortunately. Some people won't even use it in little older children. Whether or not we can use aproclonidine, well, there are now some cases in Horner's testing where it was used, where kids had some side effects. Even in older kids, it can make them sleepy. A relative contraindication is kids with Sturge-Weber syndrome who have leptomeningeal angiomatosis, the other word for Sturge-Weber syndrome, because in those children, their blood-brain barrier is even more porous. I have a child in my practice with severe bilateral Sturge-Weber syndrome and developmental delay. Instead of going under anesthesia, instead of having a sedation, when he comes to my office, because I can't examine him awake, we give him 1 drop of brimonidine, and he is completely out for a full exam under sedation with 1 drop of brimonidine. He's 12 years old. So it's pretty remarkable how this can cross. Number 2, in adults, I believe, that you try and avoid prostaglandin analogs in patients with iritis. Is that true, Sonia? In kids, it doesn't do anything. We use it in kids with iritis all the time. Number 3, aproclonidine causes, right, Sonia, in adults, they get that allergy with periocular redness and all that stuff. Doesn't happen in childhood for whatever reason, sometimes in teenagers. We also know that unlike adults, acetazolamide and topical carbonic anhydrase inhibitors are additive. They just have a lot more carbonic anhydrase than adults, and we published this some time ago. So you can use the two together and get a boosted effect. The whole idea of surgery on aphakics is totally different than in adults. Because aphakic eyes are like little mush balls, we have to take certain precautions in order, when we're doing trabeculectomy or tubes, to manage those soft eyes. In adults, many surgeons do prophylactic sclerectomies when they're doing glaucoma surgery in patients with Sturge-Weber. Sonia, do they do that here? Anybody do that?
I don't know.
What's that?
I haven't seen a surgery.
I haven't seen it. So some people do that routinely. Don't need to do that in pediatric glaucoma. In fact, I can tell you, in my career as a pediatric glaucoma doctor for lots of years, well over 20 years, I have never once drained a choroidal in a patient with Sturge-Weber. It just doesn't need to be done because they can reabsorb their fluid, unlike adults, because their pumps are so good. And we already talked about the goniotomy for uveal outgrowth. So there's many more examples of how children are unique. And that's because, and that leads us to a really important point, pediatric glaucoma is not a hobby. If you're going to be doing 3 or 4 cases of pediatric glaucoma a year, you shouldn't be doing it. It really needs to be concentrated in the hands of people who like it and do it. There are some adult glaucoma surgeons around the country, Alan Beck, Jamie Brand, Lana Grajewski, people who's a Wills grad, who do adult glaucoma, but really have made a niche in their lives for pediatric patients and see a lot of pediatric patients and try to do it. There's very few dedicated pediatric glaucoma surgeons like myself or Sharon Freeman and David Walton, because a lot of people like this. It's a hard disease to manage. It's tough, and we'll talk about that more in a second. But it's not something you should be doing as kind of like, oh, this is fun. It really does require a concentrated, dedicated look. And from experience, you learn that tip number 15 is be honest. And that's be honest with yourself and the family. And what do I mean by that? Well, each time we have a patient, we have to ask ourselves, what's the risk-benefit for this particular disease, for this level IOP, in this patient and in this family? And the answer to that question is going to be different in every kid. Some families cannot tolerate the intense, rigorous follow-up of a tube. Yesterday, I have a kid who came from Kuwait with bilateral glaucoma, who's had bilateral transplants here, and has glaucoma, and he's a tube in both eyes. And, you know, they are a very wealthy family who can afford to live at a hotel in Philadelphia for the next 2 to 3 months it's going to take for me to get this kid through a tube. I have another patient coming from India who can't do that. And I got to come up with a better plan that's going to allow this kid to return to their home country. Everything's different for every family. I have patients in inner city Philadelphia who could not do the rigorous follow-up that's required for a tube. Maybe endoscopic surgery would be better for them. So that's how we make our decisions. Yet endoscopic surgery is not good for lowering the pressure from 40 to 20. A tube is better. So it's picking the right treatment for the right eye, the right anatomy, the right disease at the right time for this child and this family. And that's tip number 16, is knowing when to quit. Now, sometimes glaucoma can tear apart a family. sometimes patching can tear apart a family. And sometimes we have to give families the permission to say, no mas, I've had enough. This is a patient of mine. The left eye is a prosthesis. The right eye is a terribly ectatic, ugly eye. She's light perception in that eye, and I've offered her enucleation many times. And she says, you know, doctor, my light perception keeps me functioning. When I have to get up to pee in the middle of the night, I can find the washroom. I want my light in this eye. And she comes back visit after visit. I do a finger tension pressure. She's on glaucoma meds. We do the best we can. Can't do any surgery except for cryo. And that's what she wants. Another patient comes to me, a very mature 15-year-old girl with sarcoid uveitic glaucoma. She's light perception in one eye, and she's hand motion in the other eye, and her pressures are in the high 30s. And I say, you need surgery. I make a recommendation for surgery. And she says, you know, doctor, I use a white cane. I go to the school for the blind. I live in a blind world. Sometimes I close my eyes in order to see better because I'm annoyed by these visual images that I get. I'd much rather be blind. Thank you, but no thank you. Walked out the door, never saw her again. So we have to make the right decision. We have to know when's enough is enough for a family. Had a patient the other day, persistent fetal vasculature, just last week, aphakic glaucoma, bad glaucoma. We're doing great with the glaucoma. Got it perfectly under control. She had a trash. She did great. Everything is good. Francesca saw this kid the other day with me. And the parents, I said, how's the patching going? I said, we cannot do patching. We've tried this shit. We feel like we're torturing our child. We're torturing our family. This is not working. We had a long conversation. Said, I get it. I understand. You've done everything. You're good parents. Not working for you. Your kid's going to be legally blind in that life for the rest of their lives. We're still going to try and control the glaucoma because we don't want it to go NLP and we don't want it to get ophthalmic and rupture. But anyway, you have to know when to stop. And lastly, examine and treat the whole family and patient. So when we see the kid with the big cup in their eye, right? We want to look to see, is it autosomal dominant physiologic cupping or is it glaucoma? So we examine the family. But we also got to consider all the psychosocial aspects of the disease which reach into the family as well. How the kid looks, the fact that they don't like to take medicines during the day or the school system can't give them their medicines, their fears of the school, the non-compliance. Teenager with uncontrolled glaucoma, number one cause, they're not taking their medicines, right? Future issues, they want to know, my kid's going to get this. It's a rare disease. They feel isolated. Patients hang on the pressure. What's the pressure today, doctor? It's 16. Yeah, but it was 14 last visit. They're so fixated because they can't see it. They can't get a handle on it. There's so many psychosocial elements of this disease. It's difficult to control. They start doing weird things. They put tea bags on the eyes. They get desperate. They lose vision. But nowadays, we do great. Most kids wind up with 20/40 vision or better with pediatric glaucoma. Parents need to know that. Parents need support for these things. That's why you should all know about the Pediatric Glaucoma and Cataract Family Association. It's wonderful. There's brochures in the clinic. It's a group of parents for parents. And this is also an integral part of caring for the child because it's not just about the child. It's about the family and the environment that they live in. That's all. Thank you very much.